researcher interested in social and cultural aspects of health in Guatemala and Central America, something that I think is pretty germane to a lot of our classes and what we talk about. Through his work, he pays particular attention to the link between public health practice and health as a human right from the perspective of sociological epidemiology. He received a medical degree in 2000 and a master's in public health in 2006, both from the University of San Carlos of Guatemala, as well as a doctorate degree in anthropology from the University of Washington in 2013. Between 2001 and 2006, Alejandro worked in rural Guatemala as a physician and primary health project coordinator. He is assistant professor in the anthropology department here at DU, and he maintains professional collaborations in Guatemala with the I'm going to mess this up, Instituto de Salud, and I'm not even going to try to pronounce that word. But
I can say Instituto de Salud Incluyente.
Excellent.
We'll talk about it.
And I'll let you talk about the other affiliations you have as well. But very happy to have him, so Alejandro, thank you.
Great, thank you. So I was not sure about what to expect, so I came prepared to go either way with the talk. And I was also told that I should be done at about 2:50.
Yes.
Yeah. So we'll see how it goes. Okay, so so the main thing that I want to talk about has to do with my dissertation work. I just chose to talk about that because I am writing some articles now, preparing a book proposal. So I'm thinking a lot about this. So preparing the talk even helped me with the manuscript preparation. And the dissertation took several years, as anthropologists like to do it. And in the end, I came up with this idea of neo-colonial epidemiology. I'm not necessarily convinced that that's the term that I will end up using. I also consider that at some point magic realism epidemiology, for instance. But anyway, I in the end felt like neo-colonial epidemiology could be, I don't know, inviting, suggestive of the main themes that I found through my research. And let me just read something here where I kind of define what that is. Guatemala, and this is just following the anthropology tradition. Anthropologists often read papers instead of give presentations, so I'm combining things here. Contemporary Guatemalan epidemiology is a quintessentially neo-colonial endeavor. If neo-colonialism can be broadly defined as the economic and political policies by which a great power indirectly maintains or extends its influence over other areas or people, it is necessary to insist that in the case of Guatemalan epidemiology, such influence is maintained and extended at various levels and through different means with distinct effects. I find the notion of neo-colonial epidemiology to be a compelling and illustrative way of synthesizing my research findings because they highlight the unequal relationships between Guatemalan epidemiologists and international epidemiologists, such as those at the Pan American Health Organization or the US Centers for Disease Control and Prevention. But at the same time, this notion highlights the role Guatemalan epidemiologists end up playing in maintaining the quasi-colonial social relations of exclusion on which the Guatemalan nation has been built. Guatemalan neo-colonial epidemiology is post-colonially undisciplined, intellectually colonized, institutionally weak, norm-obedient, fearful of the powerful, depreciatory of the powerless, marginal, egocentric, and ineffective. This is not to say that these are the characteristics of Guatemalan epidemiologists, but rather that these are the circumstances in which they operate. This is a key distinction because the vast majority of epidemiologists I met were brought to epidemiology seduced by the idea of dealing with the causes of health problems, even if that meant going against the tide, because it seemed the right thing to do. So, because I assume that you all want to make a difference and want to do the right thing. Well, same with me. It turns out that same with Guatemalan epidemiologists. But part of my argument is that it doesn't matter how nice, good, committed you are. If you end up working as an epidemiologist in Guatemala, you will end up being a neo-colonial epidemiologist, because there are these influences that really shape what you do and what you can do, and they end up shaping the way you think and the way you feel about the health situation in the country. I am using this just to try to come up with new ideas, but neo-colonial epidemiology can have different ingredients to it, just as a soup. But it is based on institutional chaos, disciplinary conformism, the international global health relations. And all these are cooked by the social relations of exclusion that prevail in the Guatemalan society. Well, as I told you, this is part of my dissertation work, so lots of people to acknowledge at UW, where I got my degree, Guatemala, money, well, lots of people helped out with this. I graduated as a physician in 2000, and by the time that I graduated, I was already working and involved with some health-related efforts in rural Guatemala. So when I graduated, I just went and worked in some pretty remote areas of the country. And just to give you an idea, this is the health house where, or one of the health houses where I worked. These are the conditions in which these people who live over there in remote areas, who are primarily poor and indigenous, get their health care. By someone like me, who, although I was always trying to learn the indigenous languages in Guatemala, and particularly Quechua, the one spoken there, I was not really fluent in Quechua, so that's what they would get. That led me to try to focus on having a broader impact, because I felt like I was not doing anything really there. People would come with diarrhea and stuff, and I will give them whatever I had, and then they would come back again next week or next month. I will go to their houses and try to come up with ideas of how to be, I don't know, drink clean water. It was really impossible. I will get sick all the time when I was there, even if I was trying to not to. So I started moving towards public health, and I got really engaged with epidemiology, because I felt like epidemiology had the potential of really focusing on what was important when you were thinking about these huge disparities in health, in access to healthcare, but mainly in health outcomes in Guatemala. So this is me moving towards more public health, working with community leaders. Now, a little bit of background. Epidemiology has been institutionalized in Guatemala only recently. In 2006, the National Epidemiology Center was created within the Ministry of Health with the mission of basically putting, the way they frame it is that they wanted to use science to the service of the people with the aim of contributing to the achievement of the right to health. That was their general idea. And epidemiological practice has gone through several changes, but basically it has gone from being very weakly institutionalized with no formally trained epidemiologists to then adapting some international regulations and trying to comply with international health-related commitments with some epidemiologists trained abroad. But then after the peace accords in Guatemala were signed, local universities started offering epidemiological training, which increased the number of epidemiologists. And that, together with the idea of modernizing the country after the Civil War, is what led to the creation of the National Epidemiology Center, which I think is a great achievement. And it was incredibly nice to learn that they were trying to focus on the right to health, or were inspired by the notion of the right to health, which is why I wanted to go and see how they were doing it. And one of the reasons why I was interested in that, in their use of the term right to health, is because it is often the case that public health goals can go against or at odds with human rights, just generally speaking, because in public health you are thinking about populations, right? You often see maps with different shades of color, and you want to intervene here, not necessarily paying attention on each of the individuals there, but mostly thinking about how can you turn that dark gray shade into a lighter one, so to speak, in the map that you are interpreting, because the lighter it is, it means that the indicators are better. So oftentimes, public health interventions and epidemiological interventions have the risk of going against human rights. Now, because not necessarily everybody knows what epidemiology supposedly is, generally speaking, epidemiology is interested in trying to understand the patterns of health and disease, who gets sick and who doesn't, who gets sick more of this and who of this, who dies of this and who doesn't, and also try to figure out why that happens. So distribution and causality is their main goal, and they do it, generally speaking, through three kinds of activities. Some of them are research-oriented, trying to understand causality. Others are more analysis of the available data to try to inform policy. Then surveillance to try to identify at an early stage when there's some epidemiologically relevant event. And then outbreak control, which is if there is such event, you go and do something about it to prevent it from spreading out. Now, some context on Guatemala. I promise not to be too thorough here, but I just want to highlight a couple of things. One is that Guatemala is a very small country, which is very close to the US, and it's very diverse. At least half of the Guatemalan population is indigenous. And also at least half of the Guatemalan population is poor. But that happens even if Guatemala is not a poor country. But it is one of the countries with higher levels of social exclusion and economic exclusion in the world. Okay, and then there are some events in the history of Guatemala that I highlighted here. And these have to do with how Guatemala or Guatemalans see themselves or ourselves in relation to other countries, but also how we differentiate among ourselves, often, most of the time, unconsciously. So we had the Mayan civilization, which already showed a social hierarchization that somehow has prevailed through time. So there's still today people who can track their ancestry, and according to their ancestry are meant to be the leaders of a community, for instance, or have some skills and knowledge that give them some sort of advantage or privileged roles in the community. And there's people who either, if they can trace their ancestry, they do not have those skills and knowledge, or are not supposed to have them. But also, most people who do not have that kind of relatively privileged background just don't know who their ancestors are. Such as myself, I don't know, I can only track my ancestry 2 generations, and then nobody knows. There are no pictures, there's no documents. So that's something that happened. Then the Spanish invasion, which formally built a colonial system based on unequal race, or unequal relationships based on race. And they did it, well, for the most part, initially by differentiating between being Spanish and being an Indian. But they also did it through some alliances with the indigenous elites. Okay, so let's say, well, and then during the colony, there was also the emergence of mixed race people, mestizos, or Latinos, as they are often called in Guatemala, which just made things more complicated in terms of the social and economic stratification, because in the end, after complicated processes, the Latinos ended up being sort of like administrators, middlemen between the Spanish elites and the indigenous peoples. So that happened. And after the Guatemalan independence, there were many revolutions, just the Latin American way, lots of revolutions through the 19th century. But one of those revolutions was the liberal revolution in 1870, and one of their achievements was that they finally were able to create a state that was, for the most part, ruled by the Latinos, or the Latino elites, I must say, because up until then, for 100 years after independence, it was still unclear if the Latinos were going to be able to be part of the political elite of the country, because I thought it was something in my... Thank you very much. I was wondering if some sort of insect was... So up until then, the Spanish, the criollos are called, known in Guatemala, those with Spanish blood, so to speak, were the only elites. So the importance of this is that after the liberal revolution in 1870, which really consolidated in the 1920s and even 1940s, or 30s really, emphasized the way in which the Guatemalan structure, social and economic structure and political structure, is really based on the exclusion of the indigenous majority and attempt at getting more and more privileges by the Ladino elite. But then you have to take into account that most of the Ladino people are also poor. So it gets kind of complicated. There is a Ladino and I also like to say white elite. Then there is the indigenous people and the Ladino poor who are just doing what they can in terms of privilege, but there definitely, even among the poor, there is discrimination from the Ladino to the indigenous people. So, okay, then the events in the 1950s and then through the Civil War have helped build a conflictual relationship between Guatemala and the United States because this coup was, well, in the 1940s, basically there was the first democratically elected president in Guatemala. Who, after 4 years or 5, I think, of being president, turned the power to another democratically elected president that was unprecedented in the country. And then that second one was not able to do so because he was in trying to develop in a capitalistic way Guatemala as a country, maybe with some nationalistic overtones that were like fashionable at the time in many parts of the world. He was touching the economic interests of what is now Chiquita Banana, basically. And if you recognize some of these faces, you will find that I think this was the president. Is it Eisenhower, maybe? Yeah. U.S. ambassador with a last name D-U-L-L-E-S. Dulles. His brother, who basically worked for the United Fruit Company. Then all the guys here, but then the Guatemalan military and other elites. And you can see the references here, how this is the president that came after the coup, and you can see the kind of relationship of subalternity, right? But then you have all the Ladino and indigenous poor basically either dead or working for the United Fruit Company. Pretty much, that's the general idea. And regardless of how objective or subjective that image is, this is a Diego Rivera mural. This notion is pretty much in Guatemalans' hearts and minds and souls. And I want to highlight the role that some of the Guatemalan elites had then, and I argue still have, in maintaining this social exclusion of the Ladino poor and the indigenous population more generally. Okay, and then there was the complicated civil war during the Cold War, and including a genocide. Okay, so what I did is that I really went and tried to understand how the epidemiologists do their work. I spent time with them, interviewed them, did some of the work that they were doing with them. And I did not really have like an agenda on what I wanted to find. I wanted to understand their successes, their challenges. And one of the interesting things that I found is that every time that they would tell me why or how they ended up becoming epidemiologists, there was always some kind of aha moment in which they decided, and it was often a hard decision to make, that they wanted to focus on what really matters. They realized that giving pills to people was not what the country needed in terms of health. And some of them were already medical specialists and decided to focus on epidemiology because they wanted to do what the country needed. And that's part of the way they tell their story. And I didn't know about that really, and I had never thought about my own path in those terms, but I realized that, well, maybe that's exactly what happened to me, and I discovered that through listening to their professional trajectories. I'll just move a little bit quickly now. So Guatemalan epidemiologists are relatively highly specialized people, and for the most part, you have one or maybe up to three in each of the country's administrative divisions. And then you have a larger team in the capital city, which is supposed to like coordinate, and then whenever they are needed, they go to each of the other parts of the country. And supposedly they work in a way that somehow they gather information and then they somehow are able to do things from the community health posts, such as the one that I showed you before, to more formal, like municipal health posts, to larger health centers, to hospitals, and to the larger national Ministry of Health. And that's what they do. They try to build a network that deals with the epidemiological stuff in Guatemala. So what I did is that I went to most of those places, spend some time with them doing what they do, which basically is really a lot of boring time in front of the computer. Then some time sitting in meetings analyzing the data, and just a few times realizing that there may be some event of epidemiological significance, and then trying to come up with all the resources to be able to go and do something about it. I also got some of those as well. But it was a lot of sitting in meetings and looking at what they were doing in their computers. And I interviewed a lot of them. So one of the interesting things that I found was that the notion of health as a human right that they were using had a very, I don't know, paradoxical implication, which was basically in order to help the marginalized populations in the country to improve their health, we have to be able to control them in a way. And one of the ways in which I found that is what was when they were talking about what they were doing in their public health priorities, one of which was controlling maternal mortality. And so their idea of what their duty was and how to perform it and how to achieve their right to health involved, in the end, what this physician told me: control our population. And that notion of controlling the population has basically the implication of you can control the subaltern groups, you cannot control the elites, you cannot. And what you start doing when you are trying to control your population for public health, with public health goals in mind, is that you end up keeping track of their behaviors and try to change their behaviors in ways that are, or maybe invasive of their lives. And that's exactly what they were doing. I went with these people to women's houses where they were trying to have them do what the public health goals told them that they should be doing. And this is a notion that was known in Europe a long time ago as medical police. So if you study the history of public health, you will hear that, well, in France, in England, in Germany, but mostly in France and England, there was the medical police, and that's exactly what they did. And supposedly public health, the new public health, as it is often referred to when you study the history of public health, the new public health was partly a reaction to the medical police model of health control, controlling the populations, controlling the vulnerable populations. So in any case, if you go into the details, it is just a paradox that in the name of the right to health, they would try to come up with measures of control of the population. Then I also tried to ask them how relevant what they learned when they were being trained as epidemiologists, how relevant was that to what they were actually doing? And there were many ways in which it was not relevant. It was either because they learned how to analyze data, but the country does not really have good data to analyze. Or they learned how to keep track in a more dynamic way of trends and tendencies in different health-related problems, but the country's infrastructure does not allow them to actually do it. Or they are able to, they know what they are supposed to do when they identify an outbreak, but then there are no resources for actually carrying out what they are supposed to do. So that was a lot of what I would hear. And the most dramatic one was that oftentimes they would, and they gave me many examples of this. When they find out that the source of a health problem has to do with some of the local elites, then they just don't do anything because they can even get killed. And those elites may be narcos, but they also can be like legal people, like no one being involved in illegal stuff. So in the end, when they would ask them about the relevance of their knowledge and their skills as epidemiologists, what they would basically ended up telling me is that they were pretty much irrelevant because they could not apply them. Then there is all the bureaucratic stuff, which involves the national bureaucracy, but also the international bureaucracies, because there are lots of regulations, laws, agreements, treaties, and stuff that the Guatemalan government is supposed to carry on, but that ends up depending on epidemiologists' work. And one of the things that they would complain about was that because the resources were so scarce, they would end up having to devote all their resources and energies to try to comply with the 2 or 3 global priorities, even if they knew that those were not necessarily the national priorities. And everybody would, each of them would tell me that. But then there was nothing that they, as a group, would say about that. So they keep working on pandemic influenza, which, I mean, please, we don't don't want the pandemic influenza to. I mean, I know the reasons why we need to keep an eye on it, but they felt frustrated because they were devoting so much energy to that, which is not necessarily happening, instead of being able to engage in things that are happening, which are not necessarily global priorities. Some of which are undernutrition, for instance. So several of them would have ideas about undernutrition or the rise of diabetes or hypertension. They had ideas about that, but nobody could really focus on that because they were focusing on the international priorities. And then there is this example, I talked about this in a talk that I gave last year. So how can I do this? Well, yeah, if you're interested in the details, I can give you the details later. But basically in 2009, 10, but really 2009, there was this episode of craziness in a very specific town. And one of the interesting things is that there was a response by the Ministry of Health. Some epidemiologists were sent. When they started taking samples, they ended up even getting the technical support by the CDC. They sent some samples to Atlanta. And when they started realizing that maybe it had to do with mental health, they even brought some psychologists and psychiatrists. To my knowledge, that's unprecedented. I have never known about such an outbreak in Guatemala that has been investigated so thoroughly, so to speak. But then, what ended up happening is that when all the samples that they collected and all the analysis that they performed did not show any evidence that this was a case of any of the diseases that are priority in their list of priorities, then they just stopped their investigation. Everybody went back to their thing and the investigation just stopped. There was a report that they were writing and they stopped writing it because it became irrelevant to the Ministry of Health and to the epidemiologists, even though the community was still really affected by the problem. The community, what they ended up doing is that they found some Mayan traditional specialists known as, the singular is Ahkij, the plural is Ahkihab, and they are gifted in reading the fire and communicating with the ancestors. So they brought them, they read the fire, and they came up with an explanation to the problem. It turned out that the problem had to do, according to the Ahkihab, had to do with the desecration of some human remains. And they recommended what to do about that. The community did it, and then the problem stopped. And what I say is, well, that's fine. I mean, that's fine. We are all into holistic stuff, and I am not the one who will say that that doesn't work or doesn't exist, because I have seen people whose lives have changed through these sorts of measures. But what is frustrating is that having all these epidemiologists and resources put into investigating the case, they stopped and they did not care about trying to figure out what happened. So in the end, when I interviewed some of the people, they would tell me, well, the Ministry of Health just came and made a mess, and then they even took some of the affected people to a hospital far away to run tests, and then they did not offer any solutions. But the Ahkihab they did. So when I then was able to talk with some of the epidemiologists in charge, these were the kinds of responses that I would get. They basically did not care about it. So this is an example, one of the many, that shows how, if you end up working as a epidemiologist in Guatemala, or if I do, I end up not caring about the people. Suffering doesn't matter. What I am looking for are tests, results that match the national priorities or the international priorities, but the people, the human beings, the individual or collective suffering involved in having such an outbreak is something, just, they're not worried about that. They don't care, they don't, even when I asked them, they thought that I was crazy for being interested in that, because it's a non-event to them, because it is not caused by one of the right viruses or toxins. So well, this is one of the examples that I found how very concretely all this notion of neo-colonial epidemiology ends up playing out. So I guess I will be repetitive here. I'll just move. So here's like a summary of the characteristics and maybe the implications I see in the way epidemiology gets performed in Guatemala or gets practiced. And what I think is that, I mean, epidemiology is not the most important thing in the world, definitely, it is not. But it could be very important, especially if epidemiologists were able to actually investigate why so many women died of birth-related causes in Guatemala, or why so many kids are malnourished, and to go to the root causes of that and to at least say them out loud. But they are not. And what is sad about it is that these are the most humanistically inclined individuals that, for whatever reason, choose the health profession, and then they realize that there's more to be done, but then they turn into managers of the status quo. And I can say that that's what I would be doing. Now, they are not like machines controlled by all this stuff. And this is another sad outcome, because the way of resisting neo-colonial epidemiology is brain drain. They end up working for someone else within Guatemala, someone else who can appreciate their skills and knowledge, or they end up migrating and maybe teaching at a US institution. And that's, I have a conflictual relationship with when I found out that that's what they do. And I was talking, I remember, with my advisor in Seattle. As I was telling her, I realized that I was part of the trend, right? Because I was trained as a public health university in Guatemala with an emphasis in epidemiology. And I ended up being unsatisfied with what I could do with that, and ended up pursuing an anthropology degree with the idea of going back and doing important stuff in Guatemala. And after 2 or 3 years, I realized that I was not going anywhere. So I feel like I can do more. We'll see. You can ask me in 5 or 10 years, or 20. Well, I guess 7, really. If it's working, but I think that I can do more from here than what I can do from there. And now, just to finish, I think that antidote to that at the local level, at the international level it's more complex, but at the local level is just to embrace the notion and the implications of social participation and addressing health inequality. If you start doing that, then your methods, the way of engaging with the communities will change. You will be more inclusive of who comes to the table when you are analyzing a problem. And lastly, what I am trying to do now is that I have given presentations in Guatemala, and we have talked about, and we are trying to see if it actually happens, about having a workshop where we can work with the schools of public health in the 3 universities that offer that program, with the epidemiologists, the Ministry of Health, and with some activists for the right to health, the 2 organizations I am connected to in Guatemala, to try to come up with, I don't know, practical implications of this, or at least to talk about it and disagree about the findings. So far, when I gave my initial presentations, people felt or expressed that this made a lot of sense to them and that they would like to change things. But I think that the changes would involve a lot of complicated institutional changes as well. So that we would need to have it be a collective effort, which I think can come out or could come after this workshop that we are planning to do. Okay, so that's it. Thank you.
Does anyone have questions? Hi Alejandro, I'm Madiha, the interim GHA director. Nice to meet you.
Yeah, very nice
and I'm an epidemiologist, by the way.
Aha.
Physician and epidemiologist. Does anyone have any questions, guys?
So in regards to like how the epidemiologists reacted to that locura, like the outbreak, how, what would be another way of reacting to that? Like what would you suggest, would be a good starting point,
Yeah, I think focusing on working with the community instead of looking at the community as the bodies that may carry the virus could work. But that would imply a different kind of training, which is not unprecedented. Even in the US, the CDC trains people for community-based research, community-based research, or participatory research. I have not witnessed how that ends up working in the field, but I have heard good things. I mean, at least it is a step in the right direction. So if you work with the community, and then if you do not focus only on the institutional priorities, but also give some importance or voice to the community's priorities or needs, I think that's a good step to start with. So it's good to try to identify the virus or the toxins or whatever. But at the same time, it's also good to understand that there is some suffering, that suffering is happening in a context, that context you do not understand very well, but people in the community may understand better. And probably the community is really interested in coming up with some sort of solution. Yeah.
So there's more collaboration.
I think so, yeah. I think if you start, I mean, if epidemiologists start looking at people not as sick bodies, carriers of toxins or viruses, or beneficiaries of what they do, and they start looking at them as human beings such as me, such as myself, I think that's a good beginning. But that can be very hard to do in the Guatemalan context because you have all these Ladino epidemiologists who don't care and maybe really look down anything that has to do with being indigenous. So what ends up happening is that you assume that these people are maybe even